According to the agenda, we have 5 minutes to have a discussion. Uh, so I can start with a question to Partha. Partha, uh, at the similar times, I did a survey in 1,500 cancer patients in gynecologic oncology, and my results were in opposite with your study. That the fear of COVID in gynecologic cancer patients was only 15%, but a great majority of the people, of the patients were actually had anxiety and depression and were angry because of the postponement of their appointments, because that they were lived outside the hospital. So the results in Europe is in the opposite compared to the developing countries. How do you comment on this? And of course, another one is maybe I see in the COVID days, the countries are fighting, competing with each other. This is similar elimination program of cervical cancer, COVID elimination program. Do you think any chance that after the COVID, we can have a similar atmosphere, HPV elimination, daily vaccination numbers, daily screening numbers in all media? Maybe COVID can have this opportunity to us. What do you think about this?
Thanks, Murad. I think what you very rightly pointed out was, we have seen different kind of responses in different countries. Even within countries, we have seen difference in activities and responses. To me, ultimately, it boils down to governance and leadership. In every country has a COVID response team, but then ask these countries how many of these COVID response teams include a NCD program manager or cancer, cervical cancer or whatever, cancer control manager. Very few, though there is a very specific recommendation for doing that. And then similarly, planning ahead, understanding that it is going to, we know about the backlogs, but then how to manage those backlogs. It really needs to be a planning that should be very inclusive. You will have to bring in different stakeholders and make sure how things actually work in your own setting. That there is no one solution that works for all. And regarding your second point, I think we published recently in the Nature, and we said that if there can be an alliance like COVAX, which can make sure that within 6 months of a pandemic starting, we have 5 vaccines in the market and more than 300 COVID detection tests. Why cannot we have that kind of alliance that will try to save our women from this deadly yet preventable cancer? So yes, I very much support your point that we need to come together and think big, think in a very big way to tackle cervical cancer.
Thank you.
I had just one quick question for Sharon. I noticed the difficulty in getting self-sampling accepted in Japan. I don't know if you could comment on that. It's, in my view, clearly the way forward for cervical screening, and just comment on how one might overcome that in Japan.
It's the gynecologists basically wanting to control everything. Yeah. So from 2016, the health ministry actually passed a law saying that nurses could also do screening, but the medical association won't allow it. And so I mean, we have done some studies in Hokkaido and it's highly accepted. The women loved it. They would like to recommend it to their friends and family. But it's only pilot studies. And because we don't have a primary HPV vaccine screening program, they also say that's another barrier. But the main barrier are the mostly male gynecologists. Yeah, that would be, sorry to say, the male barrier. Yeah,
that's
as
true.
a very patriarchal society.
There is a question from Sylvia. Maybe Partha and Yuwin can answer this. The question is there any signal, any indication that the screening visits that you restart has triggered any COVID outbreak, second wave, third wave? I mean, is there any scientific evidence for this, that you start screening and the COVID outbreak starts?
I have not come across any such publication that has looked at it that way, that, whether that kind of exposing the apparently normal, healthy women to screening facilities has, increased the risk of COVID. No, Sylvia, I have not seen any evidence. But then this is possible, but then most of the screening centers are those who are taking appropriate measures in terms of, number one, planning appointments, ensuring social distance, ensuring that the appropriate protective measures are followed both by the providers and then those women coming for screening. Probably they can provide the services in a much more safer way.
And maybe to question to Malaysia, to Professor Wu Yin, because we are doing HPV screening in Turkey for last 7 years, and one of the major problems in this conservative country is when you say a lady you're HPV positive, it produces a problem in the male to female family relations, and they usually ask, hey, I didn't have anybody in my life, and where it happened. What was the experience in this question in Malaysia? I really wonder. It's a similar population, because, and last week I did a teleconference in Greece, and for the self-sampling, I got a very, very different question from the patients, because the patients, patient advocates, the leaders, patient leaders, told me that our common slogan should be regular physician examination. So this is a common medical slogan, and self-tests, will change everything. No need for regular physical examination. So how you can explain this to the patients?
So I'll take the first question first. The issue of stigma and HPV testing, I think it's a global problem and different extents in different population. And what we have noticed is that the women who have higher literacy rates are actually having more issues with stigma. Whereas just as we introduced our HPV vaccination program 10 years ago, we market it very much as a cancer vaccine and a cancer screen. So even now, when we do the screening test, they call it, the women themselves have called it a DIY cancer screening test. They don't call it a sexually transmitted disease, or we don't link it to that. And so for Rose Foundation, we actually target our educational material for those with lower literacy rates. So lots of visuals, lots of short videos, and not so much linking it as an infectious disease. I think that's quite important. They just need to know they need to get this done, and it will reduce their risk of cancer. So that's the first thing. So our team in the university will now be systematically documenting the levels of stigma and stress to the educational levels in rural and urban areas. That's being done now, and we are lending on the expertise, or borrowing the expertise from our HIV colleagues. Women here have no issues with self-sampling, really similar to Sharon. I think most of the doubt initially were from clinicians. And it helps that being a female gynae oncologist in Malaysia and saying that self-sampling works and pushing that forward as an agenda, they now know that everywhere I go, I have a self-sample either in my pocket, in my car, in my bag. Anywhere I go, the swab comes out. So I think getting the message out is very helpful.
Okay. Jack, there was a question from Julie, actually, but our time is ending. The question is, Is there any example of HPV screening workforce being jointly trained alongside COVID testing? At least I can answer from Turkey. It's not jointly trained, but they are working now. I mean, HPV screening people are now working in COVID screening. So it's interchangeable, not training, but the health care people is interchangeably used. Any comment for this question of Julie from UICC?
Yeah, Murat, in our study that in which we interviewed 18 program managers from 17 countries, only 3 program managers said that their training of the health workers, or rather health professionals in COVID-related issues included how to manage screening services. Out of 18, only 3. But the rest, they say, no, our the workers were just trained to manage, COVID-related issues, but nothing specific on cancer screening, how to improve or how to protect women from cancer screening.
Yeah,
there's a big gap.
And one last question, and let's finish the discussion after this. The question is to you from Sylvia to Partha. There is a nature paper using cell phone activity showing that going to a health center in the US increased the risk of acquiring COVID. But I have not seen this data for low middle income countries. I mean, it's an answer to that. There is a publication actually, what Sylvia says, that screening can be a cause for the second wave. I'm very concerned that in many settings, the condition to promote screening is safe, but may not be good enough.
Agree, Sylvia. It is good, important to keep tab on these issues.
Jack?
Okay. Thank you very much, everybody. We've slightly gone over time, but we'll now, I guess, move on directly to the next session with new chairman. And thank you very much for your attention. Very great session. Plenty of room for more questions. I'll talk a little bit about self-sampling a little later in the morning, but lots of great things happening. So thank you all for your contributions. Really excellent session.